Good morning, everyone. It gives me immense pleasure to welcome you and to our exclusive webinar on exam preparation for oral and maxillofacial surgery. Today, we are honored to have a distinguished expert in the field, Dr. Padma Preetha Balaji, joining us as our esteemed speaker today. Dr. Padma Preetha Balaji is not just a qualified oral and maxillofacial surgeon, but a visionary educator with a deep understanding of the subject and the evolving needs of students and teachers in the current educational space. Being recognized as the best outgoing MDS student at her institution is a testament to Dr. Preetha Balaji's unwavering dedication and exemplary work ethic. She is a prolific author of numerous national and international research articles, illustrating her commitment to advancing the field of medical surgery. Having recently been a student herself, Dr. Padma has invaluable first-hand insight into the needs of the student community, challenging this knowledge to create student-centric improvements in the oral surgery textbooks tailored to the exacting needs of current curriculum requirements. Today, we welcome Dr. Padma Preetha Balaji, an exemplary leader and educator, as she shares her wisdom, experience, and expert guidance with us in this exclusive webinar session for you. Over to you, ma'am.
Thank you, Nancy. Thank you for the lovely introduction. And good morning to all of you students. So most of you are going to be writing an exam in another 10 days or so. I have received a few topics that you wanted me to discuss with you. So there are 6 topics. I hope this session will be useful for you. And if you have any doubts, please do put it up in the chat so I can go through it later. So let me just share my screen. So, yeah. So today's agenda will be these 6 topics. I will be starting with local anesthesia since that's the most important and basic. And it is very important from a Viva point of view and from your exam point of view also. Luckily, I got to go through your question papers. I think I got about 20 papers from the Kerala universities. And most of them had most of these topics that I'm discussing today. So I was very happy about that. So first, I'll be speaking about local anesthesia, then pre-prosthetic surgery, maxillary sinus, oroantral fistula, impaction, TMJ ankylosis, and maxillofacial trauma. All of these 6 topics have been asked as essays so many times. And I think this session is going to help you with that. I will be brushing through. I will not be explaining everything, but I've marked what all is important. And I hope you understand. In case you want me to be more detailed and more explanation is required, please do let me know at the end of the session so I can go back and explain it to you. So local anesthesia. The definition of local anesthesia is very important. It's a Viva question. It is defined as a transient and completely reversible loss of sensation in an area of the body caused by depression of the excitation in the nerve endings and inhibition of the conduction process in the peripheral nerve. Composition of local anesthesia. All of you know this. This is a very important question. Every examiner will ask you this question at your Viva, and it is an important 3 mark or a 4 mark. Please take a screenshot of it. Please memorize it. And in this table, I have discussed what is the function of the agent and what all agents are there. These 9 points should be mentioned when you're asked this for your exam. The most important points being, of course, lignocaine. It is the anesthetic agent, and adrenaline, because it's going to cause a vasoconstriction and it increases the depth and the duration of anesthesia. And then I noticed this, I added this slide last minute because I noticed that this was a part of an essay in one of the question papers. So mode of impulsive conduction, I can explain this to you. It's just how our body is going to be aware of the pain. That is what this is all about. So what De Jong stated was that the impulses conducts through a nerve, like how a gunpowder gets activated along the fuse that it burns. So that is similar to how the stimulus runs through in the nerve. That is De Jong's principle. Now, when it comes to the electrophysiology and the electrochemistry of nerve conduction, you need to know this. You need to know this graph here. Sorry, just a second. I'll get my pointer up. I'm not sure how to get that on, but if you see the graph over here, you can see that on one side, on the x-axis and the y-axis, there's this resting potential and the time. So resting potential or the stimulus, it has to reach a threshold. The threshold is minus 55 MV. So once the stimulus, if the stimulus does not reach it, like in the yellow line on the graph, if you can see, those are stimulus that did not reach the threshold, minus 55 MV. If it does not reach it, it will fail to reach this threshold and it will just go up. So it will not initiate any kind of impulse. Once a threshold is reached, there is a rapid depolarization. That is step 3. Step 1 is slow depolarization that is mentioned here in the electrophysiology of nerve conduction. So basically what happens is, if you see the figure B, in that the first part, you will see that action potential is described as black arrows. There is an influx of sodium inside the nerve cell. So when there is an influx of sodium, the potential increases inside the nerve cell. And in that case, when it reaches above when it goes to minus 55 MV from minus 70, when it goes up to minus 55 MV, the threshold potential reaches. And as soon as the threshold reaches, there is a rapid depolarization of the nerve. And it reaches the peak of action potential. That is in the step 3. And step 4, what happens is there's a rapid repolarization where sodium ions enter the cell again for the next threshold to start. So this is the mode of conduction of nociception. The next most important is theories of mechanism of action of local anesthesia. This is also a part of PSA. In this, specific receptor hypothesis is the most favored, and it is also a viva question. Please make sure that you read it and understand it. This, you can take a screenshot of it. This is a very simplified way and easy way for you to understand this. So in specific receptor theory, local anesthesia is it goes and binds at a specific receptor inside the nerve membrane. So once the local anesthetic agent goes and binds inside the nerve membrane, there is going to be no sensation of pain. So that is what specific receptor hypothesis is. Then we have a classification of local anesthesia, again a viva voce question and a 3-mark or a 4-mark question. So please make sure you know the ester and amide classification very well. And the duration of action classification is also important. Make sure you know that bupivacaine is a long-acting agent. That's a very common question they ask. And that lignocaine is a part of an ultra-short-acting. Lignocaine as a block is an intermediate acting, but lignocaine as a plain anesthetic agent can be used as an infiltration. In that case, it is an ultra short acting agent. So make sure you know all of that. Now, this is another question. Why does LA not work in infected tissues? So what happens is, when you take the structure of a local anesthetic salt, it is an acid salt of a weak base. That is why it is described as RnHCl. HCl is an acid, you know that. So RnHCl is an acid salt. So that is how the local anesthetic agent is inside the vial. So once you inject it into the patient's mouth, inside the environment where it has to act. It has to dissociate into a free base. That is, it has to convert into R and HOH. So in this situation, you need an area, the patient's mouth or the area where the agent is going to work has to be in a pH of 7.4. If the pH is going to decrease, as in an infection, the pH will be 5 to 6. In that state, the local anesthetic agent will not work because it will not convert from acid salt to a free base. So that is why LA won't work in infected tissues. So the treatment for this is you have to add in sodium bicarbonate. Sodium bicarbonate will increase the pH of the infected tissue. Then the ideal properties of local anesthetics is also an important question. Please go through it. Now, maximum recommended dosage. This is also a very favorite question for Viva OC. And yeah, so if you take this table, I prepared this for you. So you have to memorize all of the points inside the table that's given in bold. So you need to know that the maximum dosage of lidocaine is 4.4 mg per kg. You have to memorize that. And then you also have to know that one cartridge, because see, we do not use cartridge in India, but in foreign author books, it's always mentioned in cartridges. And still in other countries, they do use cartridge. So one cartridge is going to be 1.8 ml. So so they ask you how many cartridge is going to be used maximum. So when they ask you these questions, you need to know this calculation. So when you take maximum dosage of lidocaine, that's 4.4 mg per kg. For a normal healthy male, he's going to be around 70 kgs. So 4.4 into 70. So maximum recommended dosage is 300 mg. So now you need to know how much 300 mg is going to be in how many ml. Now we'll see the cartridge calculation. So one cartridge is 1.8 ml. So per cartridge is going to contain 36 mg of lidocaine. So how many cartridges can be used? That is 300 divided by 36, 8.3 cartridges. But what is the maximum recommended dosage in ml that can be given? That is for us. That is 15 ml. You can give 15 ml of local anesthetic to a healthy 70 kg male, and that should be the maximum. You can't give more than that. We give 2 ml, 3 ml maximum. So it shouldn't be an issue. Unless you get a failed block during your your practical exam, and you keep on trying again, then you can go above the maximum recommended dosage. This question is usually asked in case your block fails during your practical exam. Your examiner may ask what your maximum recommended dosage is. You can confidently say that it is 15 ml. So next, the maximum dosage of lidocaine with adrenaline. So I was discussing plain lidocaine. Now lidocaine with adrenaline. Now you have to talk about adrenaline. So how much of adrenaline is safe? In this case, you need to know ASA classification. ASA classification is the American Society of Anesthesiology. This you would have come across in GA chapter. So ASA classification, patients are divided into six categories. So in which category 1 is a normal healthy male. For other category, and even category 2 is mild systemic disease. So these two categories, you will not have much of a difference. But when it comes to ASA 3 and 4, you will have to reduce the amount of adrenaline that you give in their system, because most of them have heart disease, and adrenaline is very sensitive for heart patients. So when you take an ASA 1 patient, there is 0.2 mg maximum per visit. So you cannot exceed 0.2 mg per visit for a normal healthy individual. But for a patient with ASA 3 or ASA 4, maximum is 0.04 mg per visit. So which is only 24.5 ml of lidocaine. Now, pharmacology of vasoconstrictors. This is not very usually asked, but if they ask, they're going to ask about your classification of vasoconstrictors. You can just memorize that. Nothing else is important to this. Next, basic injection techniques. How do you deliver LA to a patient? So you can give a nerve block, a field block, or a local infiltration. Usually what we give in the oral cavity is a nerve block, like inferior alveolar nerve block, posterior superior alveolar nerve block, infraorbital nerve block. So all these are nerve blocks because you are blocking one particular nerve. But when it comes to a palatal infiltration, the palatal nerve is the posterior area. But if you're going to remove an upper one, in that case, you're going to give an palatal infiltration. There, you're not really blocking the entire nerve. You're only blocking that part of the mucosa. So that's called a local infiltration. So like a supraperiosteal infiltration is given for any one tooth extraction. So only that particular area is going to get the local anesthesia. So techniques. So these are the techniques for maxillary anesthesia. I can just go through with you. So there's intraoral technique and extraoral technique. Intraoral technique is the posterior superior alveolar nerve, the middle superior alveolar nerve, the anterior superior alveolar nerve. And the anterior superior alveolar nerve, you have three approaches. So one is the bicuspid approach, then the central incisor approach, then the extraoral approach. So these are the intraoral techniques for nerve blocks for the maxilla. Now for extraoral techniques, there's palatal anesthesia. So I'm sorry, actually greater palatine nerve block comes off in the intraoral technique. I think I made a mistake over there. The nasopalatine nerve block and the other for maxillary nerve block, the maxillary nerve block is given via the greater palatine canal and then through the pterygomandibular fissure. All that is an extraoral thing. Again, infraorbital nerve block can be given through the mouth or outside also, like directly. So now you have asked only for posterior superior alveolar nerve block. So I'll discuss that. In this, the most important point is that this block is going to anesthetize only the first molar except the mesiobuccal root, and then the third molar and the second molar when it comes to the tooth. Apart from that, the buccal periodontium and the bone overlying the teeth are going to be anesthetized. So the other names are tuberosity block and zygomatic block. How do you give this? Can you see in the image there's a red color, the teeth have been marked as red and the nerve is also marked in red. So that is exactly where you're going to be depositing the solution. So you have to place your index finger over the mucobuccal fold near the bicuspid, move it posteriorly, and then place the needle in at an angle of 45 degrees. All right, and then inject. I think you'll be injecting 0.8 ml, which is not mentioned in the slide, but yeah. And so yeah, in this image C, you can see how we give it for the patients in a clinical setting. So complication of PSA nerve block is injury to the pterygoid plexus of veins, which is the posterior area behind the tooth. So in that case, patient can develop a hematoma. So that's also an important point. Infraorbital nerve block. In this nerve block, we are going to block this area. You can see on the image. So the area is the overlying tissues of the upper lip, the side of the nose, under the lower eyelid. And then when it comes to teeth, it's going to be the incisors and the bicuspid. The landmark for this is the pupil of the eye, because that is exactly where the intraorbital notch can be felt on palpation. And how you give this is you hold the upper lip and pull it up apart. You insert the needle at the height of the nasolabial fold and go upward and a little bit posteriorly. So when you feel for the notch and you deposit the solution at the infraorbital foramen, the nerve is going to be blocked. So you should make sure that the needle, you can see in the skull image exactly where the needle is placed. That's exactly where, that is 0.3 mm into the foramen. So yeah, so that's where you're depositing it. Oh, okay, so complications, these are complications. These are the other techniques for mandibular anesthesia. I'm sure you all know all of this. I'll be discussing only direct and indirect in this. So inferior alveolar nerve block, you're going, the nerves anesthetized have been given here. The landmarks are here. So in the direct technique, Halsey's approach, you're going to block inferior alveolar nerve first, then the lingual nerve, and then the long buccal nerve. In the indirect technique, the long buccal first, the lingual nerve, and then the inferior alveolar nerve. So this is the technique. First, we are giving the inferior alveolar nerve, and then the lingual nerve, and then the long buccal nerve. This is another essay, complications of local anesthesia. So in this, so the soft tissue injury can occur during anesthesia. Toxicity of the drug. This is a systemic complication. When there is a mild overdose and there's a severe or a moderate overdose, we give a midazolam 1 mg per ml based on how the toxicity is. Then we have allergy to the drug, burning sensation. You can take a screenshot and go through it later because I will not be having time to finish it. So trismus is an essay. So trismus, why trismus happens is mostly it will happen for an inferior alveolar nerve block. And this is because when we are piercing through, we pierce through the muscle and deposit the local anesthesia solution. So the medial pterygoid is attached to the inferior side of the mandible, and that's the area, the pterygo, that's the space, the pterygoid. So that space is where you deposit the LA solution, the medial area between the ramus and the pterygoid muscle, medial pterygoid muscle. So when you cross through with your needle, you're going to injure the muscle. So patient is going to have some inflammation, and that is why they have trismus. So you can go through this. Please take a screenshot again. So facial nerve paralysis is an important complication. It occurs for patients because the angulation of the needle during inferior alveolar nerve block is changed. If you go too much anteriorly, you might deposit the local anesthesia solution into the parotid capsule. So the facial nerve is within the gland. So in that time, the patient can have a facial nerve paralysis. Diplopia can also occur. That can happen when you give the anesthesia solution is deposited near the lateral rectus in intraorbital nerve block. So this is the posterior alveolar nerve block where pterygoid plexus of veins can get damaged. Hematoma can be formed. So this is local. These are the complications. You can see facial palsy in C and D, and diplopia in B, and A is needle breakage in the pterygomandibular raphe area. So next topic is impaction. So impaction, a tooth when it is partially or completely unerupted, it is positioned against another tooth or a bone or a soft tissue. It's called impaction. So impaction, the tooth can be a soft tissue impaction or a hard tissue impaction. The most commonly impacted tooth is the mandibular third molar. So followed by the maxillary third molar and then the maxillary cuspid. So this is a Viva question. Apart from that, theories of impaction, I'm sure you'll all have gone through this. Very easy one. So please take a screenshot or make note of it and go through it. So in this, Winter classification has been asked as 3 marks. So we'll go through that. So Winter classification, it's a very easy classification and everyone know this. It's either mesioangular, distoangular, horizontal, vertical, buccal, lingual or transverse. So all of this is based on the second molar. So if the if the long axis of the third molar is going to be above the occlusal plane of the second molar, it is, and if it's going to bisect the long axis of the second molar, then it is mesioangular. Distoangular is going to be away from the long axis of the second molar. Horizontal is going to be at perpendicular. Then vertical is going to be parallel. All of this. So all of that is explained in this image. Then Pell and Gregory classification is a short note for you. So please make sure you know this. Please memorize it. It's an easy classification. If you go through, you're going to know it. Then these classifications are not that important, so we can skip this for now. This is a Viva question, I guess. No, this is a short note. Impacted maxillary canines. So class 1, 2, 3, 4, 5. So class 1, impacted cuspid is in the palate. The second image is showing that. So in the palate, it can either be horizontal, vertical, or semi-vertical. Then class 2 is going to be on the buccal surface. The above image, you can see that horizontal, vertical, and semi-vertical again. Class 3, the canines are both in the palatal process and the maxillary process. That is, the crown is in the palate. I mean, crown is in the palate, and the root passes through between the teeth. So in that case, it's a class 3. Class 4, it is vertically in between the incision and the premolar. And then class 5 is when it is in an edentulous maxilla. Now, yeah, field and Ackermann classification is also important, has been asked for maxillary canines. Please go through this also. You can take a screenshot and go through it later. WAR lines, this is very important. So WAR, white, amber, and red line, you can see that in the image. So white line is going to be the line that's connecting all of the occlusal surface of the other teeth, the second molar and the first molar. Amber line is the line that's going to be drawn over the external oblique ridge. On the image, you can see that, and then it will go and connect to the septum of bone in between the first and the second molar. And red line is a line that is drawn at the point of application. Point of application is an imaginary place on the third molar where you imagine to put the elevator and pull it up. So that's the yellow dot on the image C. So from that dot to the amber line, that's the red line. So now we measure the red line. If it's going to be below 5 millimeter, it is a less difficult case. It's not a difficult case. Easily the tooth will come out. Now, if it's for every 1 millimeter increase, that is 6 mm, it becomes more difficult by 3 times. So if it's going to be more than 5 mm, mostly it is advised to be removed under GA. And if it's going to be above 9 mm, it's going to be very difficult, and the second molar may get damaged during the removal. WARF assessment is important. It's important for PGs for sure, but you can also go through it in case they ask for your Viva. Now, pedestin scale is not that important. Now, these are steps of removal of an impacted teeth. So, first thing you do is clinically assess the tooth, and then radiographically assess the tooth, and then you put the incision. What incision is a short note. I'll go through it later. Then we have types of incision. All that is not important, and then you have to talk about elevating the flap. So when we elevate the periosteum. We raise the buccal mucoperiosteal flap, meaning the mucus and the periosteum should be removed. Only then the bone can be exposed. See, now in step 7, you can see the image. You can see the bone around the tooth. That is because the periosteum was stripped off. So that's an important point. And then in step 7, you can see that they have already guttered around the tooth. This technique is called as Moore-Gilbey collar technique. And then you remove the tooth either by splitting the tooth or as a whole, depending on how much space is available. So after that, wound debridement, irrigation, check if the wound is fine, and then do the closure. And yeah, before doing that, you have to check for any sharp edges, remove it, and then only close. So these are the different types of incisions available. What incision is in 5 marks. Please screenshot, please go through it. I don't really have time for all of that. Please go through it. Now, postage stamp technique. It is one of the techniques. Moore and Gilbey collar technique is a 5 mark for you. So in this, basically what we do is the A image is before doing the guttering with the burr. So you just put postage, just like how in postage stamp we put dots. In that we use a circular drill. In this we use a 703 drill and go around the bone, around the tooth, remove all of the bone, and then create the space and then elevate the tooth. These are questions they ask for Viva. Please go through the instructions that patient will have to follow. The most important instruction is for the first 24 hours, nothing hot has to be kept anywhere around the face. They shouldn't have anything hot to drink or eat or any kind of um, pack. Everything should be cold for the first 24 hours. Patient can go for a warm saline goggle. Complications, swelling, trismus, bleeding, and neurological complications. Neurological complications happen when you do not elevate the periosteum, the lingual side, because the lingual flap is going to have the lingual nerve. So the lingual side, I did not mention that earlier. So can you see an instrument in image B, or image A also? That is a Howard's instrument. It has elevated the lingual flap and it is protecting the lingual nerve, which is right behind that instrument. So that is very important to protect the lingual nerve to prevent paresthesia of the tongue. Now, if inferior alveolar nerve is damaged, where will this nerve get damaged? That is after removing the tooth, or while removing the tooth root is like a hook or something, and it hurts the nerve, then inferior alveolar nerve damage can happen. Again, inferior nerve damage can happen when the burr is going on the inferior side of the third molar. So that, again, that is where the inferior nerve can be. So in that area, the burr has to be used very carefully after proper radiological investigation. Pre-prosthetic surgery. So pre-prosthetic surgery is when we are preparing the mouth for dental prosthesis or denture or for implants. Nowadays, we don't use that much of dentures. Implants need pre-prosthetic surgery, mainly for ridge augmentation, but not just ridge augmentation, but also for vestibuloplasty and other things. I will talk about all of them. So the main reason we need this is because of residual ridge resorption. That's something that, sorry, just a second. So yeah, that is something that you cannot escape from. So all patients have ridge resorption. So all patients have ridge resorption. And in this case, you can see that we've classified it, Crawford and Howell has classified it as 6 types. Class 1 is dentate. Class 2 is immediate post-extraction. So in this, a buccal wall defect can be present. See, when we are extracting the tooth, we give a buccal traction. So in that buccal traction itself, the buccal bone may get damaged. So that is class 2. Now, class 3 is when the ridge has to be in a convex form. Now, class 4 is when the ridge has a knife edge form. Class 5 is when it is flat and the alveolus is completely disturbed. Class 6 is when there's a complete loss of the basal bone. That's in edentulous patients and all that. So now indications, please take a screenshot. The most important indication is complete or partial edentulism. And if the patient has any kind of bony spicule and all that, in that case we do it. And when patient has loss of alveolus, we do pre-prosthetic surgery. We create the alveolus by doing ridge augmentation with grafts and all that. So now contraindications is when the patient has a medically compromised, can be osteoporosis, hyperparathyroidism, all of these things. Now, techniques, we need to understand the soft tissue. The most important thing that you need to understand is frenectomy, where we remove the frenums, because these frenums can cause the denture to fall out and all that. Now, vestibuloplasty is done for ridge extension. Sometimes the patient will have a very shallow vestibule. In that case, you have to do a vestibuloplasty and extend the vestibule. Now, apart from that, if they have some kind of a pathology, alveolar flabby ridge or a denture granulomapillus fissuratum, all of these things are present, then you'll have to do a pre-prosthetic surgery for the soft tissue. And also mental nerve repositioning. Sometimes when the patient has in a very old patient, they have a class 6 type of defect, then the inferior alveolar nerve is going to be in a superior place. When they make a denture, the nerve can get impinged and the patient may have trigeminal nerve-like symptoms itself. So in that case, what we do is we remove the inferior alveolar nerve and reposition it. Nowadays, we are doing that for patients for implant surgery also, when the nerve is in a very superior area and they go through pathology like cases like an OKC or something of that kind. Then we do a mental nerve repositioning for the patient. So apart from this, we can go for the heart tissue. Heart tissue is the most important. Okay. So in this, we have alveolar ridge reconstruction, basically. I'll discuss that as we go forward. So alveoloplasty is the most basic. It's alveoloplasty, the primary alveoloplasty is very good and important because as soon as you remove the tooth, you know where the sharp points are, do an alveoloplasty and then close it up. The patient's going to have a very good prognosis. Dean's intraseptal alveoloplasty is specifically for anterior maxilla. I think this is a 5-mark question. Please go through. So in this, what we do is we remove all of the septal bone in between. As you can see in the second image, we remove all the septal bone. Sometimes we do it until the premolars also. Mostly it is done from canine to canine, but we can also do it until the premolar and then do a fracture. So after we remove the bone, you can see in the fifth picture, we do a down fracture. We compress both the palatal and the labial bone together. It fractures and then we suture it up. In this case, what happens is the U-shaped form of the alveolus is obtained. Secondary alveoloplasty is done as a separate procedure after extraction. The patient has a complete healing, and during the healing, what happens is they have some irritation, some discomfort, some irregularities in the bone. In that case, an incision is made, a flap is elevated, it's called an envelope flap. Because we only open in that area where the issue is, and then we do bone filing using rongers or burrs or whatever is required, and then do a digital palpation, make sure it is uniform, and then closure. Tori removal, again, for palate, we can remove it as shown in the image. That's a maxillary tori. This is a mandibular tori. You can see image C and D. We also do mylohyoid ridge reduction. Sometimes mylohyoid can be placed in a much higher level and that can cause dislodgement of the denture. So in that case, we can do a mylohyoid ridge reduction. Genial tubercles can also be reduced. For some patients, genial tubercle can be very prominent as shown in the image. Just do an envelope flap and remove it and then suture it back. Maxillary tuberosity reduction. Tuberoplasty for the dentures again. When denture cannot be taken in as when the seal is not there properly, then we do this. This is repositioning of the inferior alveolar nerve. Alveolar ridge augmentation. So this is what we do mostly nowadays because we have a lot of implant patients. We can use autogenous bone grafts like the iliac crest, the rib graft, the allogenic bone, the freeze-dried bone from the cadaver. All of these can be used. So type superior augmentation. This is where, see, in this image you can see that there is a defect in the image. In B image, you can see that we have placed the rib graft with an RHBMP. So when we place this and then suture it back, this is a superior border augmentation. The superior part of the alveolus is being reconstructed with the autogenous bone graft. So inferior border is when they do the same with the rib graft. So we have to take 2 ribs and place it on both sides on the inferior border. This helps to increase the height of the mandible. So viscer osteotomy, how do we place this graft? Is either with viscer osteotomy or a modified viscer osteotomy. Viscer osteotomy is when you make a sagittal kind of cut, like all through, and then fracture the alveolus and elevate it. So this is the first image shows that it's going to have a knife kind of edge. Because only half of the alveolus is being used. But in modified viscer osteotomy, they give a horizontal cut on the anterior portion and a sagittal cut in the posterior portion. So this is modified viscer osteotomy. Sinus augmentation, again, you make a Cardwell look kind of approach. you make a window on the bony side of the maxilla, the sinus, and then elevate the maxillary, the soft tissue, and then place your graft inside, and then you can place an implant in the image later on. So these are the types of grafts that you can place over there. Alveolar ridge distraction. Again, when the ridge is so short in A, you can place a distraction device, and then like in image E, that's a proper distractor that has been applied on this patient. And every day we keep turning the distractor 1 millimeter, and the bone will start growing, and that's how you get a proper alveolus for defect. You can compare the defects from C and D and see the. So freenectomy, there are so many techniques. Just please make sure you write down all of these techniques, these 7 points: scissor excision, electrosurgery, laser freenectomy, wedge dissection, freenotomy. Freenotomy is just when you just cut the frenum off and then suture it. Z-plasty. Z-plasty is when you make a Z-shaped incision and then reposition it and then suture it. This will help to lengthen the frenum. So that's Z-plasty. VY is again triangular excision. This is the most common technique that we do. We do a triangular excision and then suture it longitudinally, like in the image shown for lingual freenectomy. Now, vestibuloplasty, there are types again. This is a 5 mark, I guess. Please go through. So this is a closed type of vestibuloplasty. Basically, we put a line, an incision in the anterior part of the maxilla, and we do a pocketing kind of dissection. Only this is going to be a supraperiosteal dissection. So only the skin and the connective tissue under it will be dissected. And once we finish dissection, we keep we take an impression with the patient's denture itself, and then we do the suturing, or we can either do suturing, or in other techniques, we can add a skin graft. So this is pocket iliac vestibuloplasty described by Orbigisa. In this, what happens is we create 2 pockets from the lateral towards the pyriform aperture. It's the same technique as the previous one. This is Kazanjian technique. The first image shows Kazanjian technique, where for the lower lip, we make an incision on the lower inner part of the lower lip, and then pull the flap down and suture it at the base of the sulcus. So the vestibule gets extended. But this the most common issue with this is scar contraction, and the lower lip can protrude out when the scar gets contracted. And this is Godwin's technique. It's a similar technique to Kazanjian, but in this they keep zinc oxide eugenol and allow again secondary epithelialization only. Clark's technique is a similar technique, but over here what they do is they put the incision on the alveolus. Again, it's a split thickness incision. You don't put the incision onto the periosteum. Only a supraperiosteal dissection is done. So the raw area is left on the alveolus, and then the vestibuloplasty is done, and extending the vestibule into the sulcus. This is Trauner's technique, Cardwell's techniques. They are not very important. So please look at the diagram. You can take a screenshot and go through later. Orbigisa's technique. So epilis fissuratum, all these pathologies, you have to clear it up before you send the patient for a prosthesis. Maxillary sinus and oroantral fistula. So in this, the most important point was oroantral fistula. With maxillary sinus disorder, oroantral fistula is a communication that happens between the mouth and the antrum. So when this happens is after extraction, post-extraction usually happens. And the most important point is how you treat this. So immediate treatment is always better, but in some cases, if you're able to close up the flap, you don't really have to do an extensive surgery. But if the surgery is going to keep on, So how do you figure out if the patient has oroantral fistula? So these are the most important points. You will have to memorize this, please. This is a Viva question. So nose blowing test. What we do is we keep a cotton whisk near the fistulous opening inside the patient's mouth. And we ask the patient to close their nostril, open the mouth, and blow the nose. What happens? The air is going to escape through the oroantral fistula, and the cotton is going to wisp up. So when it moves, you know that there is an antral communication. So this is nose blowing test. Next is mouth mirror test. We keep a mouth mirror instead of the cotton, and again make the patient do the exact same motion. This motion where they close their nose and blow is called as Valsalva manner. So we keep a mouth mirror, and then Valsalva manner is done. The mirror gets fogged up. Next is sinus probing. This is something you should not do if you suspect an oroantral fistula, because it can cause an acute oroantral communication, and it can worsen it. In case there's a blood clot that can heal up and not cause an oroantral fistula. So sinus probing is not indicated. Next is water holding test. We ask the patient to hold water inside their mouth, and to have a difference between nasal fluid and the water from the mouth, you can mix betadine and then make the patient hold. What happens is the water will come out through the antrum and flow out through their mouth. Then radiological examination. This is the best way to detect oroantral communication, that is through CT scan. Symptoms. Remember the 5 P's. Patient is going to have pain, purulent nasal discharge, postnasal drip, and possible systemic toxemic conditions like fever, anorexia, malaise, frontal headaches. And then sometimes they may develop a polyp in a chronic condition. They may develop a polyp, and that polyp may keep popping out through the fistula. The polyp will look like a bluish red color bulge. The signs of oral antral fistula is that it can be either an early sign or a late sign. The late sign is when the patient has sinusitis, rhinitis, and they have escape of fluid through this. The early signs have already discussed. Management of acute oroantral fistula, immediate closure. See, immediate closure is only possible immediately after extraction. You see that there might be a fistula. You can make an advancement flap. So you give a releasing incisions all through the extracted area and pull it up, and then closure. This is immediate closure. So other surgical options. These are all for chronic cases of oroantral fistula. So you can use a graft to close it if there is too much of bone loss. That is a very difficult technique, but most commonly used are these local flaps. This is what you need to learn. So please make sure that you memorize this buccal flap. Buccal flap is the essay for you. So buccal flap, Reherman, Moxia flap, palatal flap, buccal pad, fat, graft, and flap, free mucosal graft, subepithelial connective tissue graft. Apart from that, if it's a major oroantral fistula caused by post-cancer defect and all that, then we can go for major flaps. Like you can also go for ALT flap or a free fibula flap without the bone, or you can do a tongue flap or an auric ear graft flap. Temporalis muscle flap. All these flaps can also be done. Now for buccal flap, one Reherman flap. So this is, I'm not sure if it's an essay or a 5 mark, please go through. So in this, what we do is, we just do an advancement flap. Can you see the incision in the third image? So that's how the incision is made. You just advance the flap and then close it, suture it up to the palate. See the last image, and that's how the oroantral communication is closed. But most of the time, buccal flaps can fail, because if there's an infection and all that, it will fail. So palatal Ashley flap, this is a very good flap. We've done so many cases, and it has always been a success, because this flap takes a pedicle. The flap is based on the greater palatine artery. You know where the greater palatine artery is in that image. In the C image, you can see the flap, and the greater palatine artery is right below it. So the blood supply for that flap is from the greater palatine artery, and it will definitely, invariably, it will close the defect. So Ashley flap is better than buccal flap from my perspective, but yeah, but both questions can be asked for your exams, so please make a note. Combination method. So this is done when the re-repair is not going to work. So what they do is they put another metallic foil to close any kind of infection or anything harming the flap. So they put a metallic foil patch and then do the closure. Buccal pad of fat graft is also pretty good. What they do is they remove the buccal pad of fat, place it in that area, and then suture it up. So the buccal pad of fat will close the defect and also re-epithelize. This bridge flap, moving the alveolar tissue from the anterior area to the posterior area to cover the defect. Post-operative care, antibiotics, analgesics, nasal drops, and mechanical support for the flap. Like, you can give a denture or something to protect from food and all that. Nasal antrostomy can also be performed through FES surgery. So, yeah. So Cardwell look procedure, it is done when there's a nasoantral, when you need a drainage for the antrum through the maxillary sinus. So in this procedure, the incision is important. We start at the canine and till the second molar. We need to expose as much. We usually do this procedure when we need to take something out of the sinus, like a broken tooth fragment or an implant itself. This procedure has been performed so many times when the implant gets stuck inside the sinus. So we elevate the flap, we give a bony window, remove open up the soft tissue, and you should make sure that the opening is going to be bigger than the object inside. So once you have full access, remove the object, clean up the sinus completely, irrigate it, do some betadine irrigation, and then close it up. That's the surgical procedure. You take a screenshot and go through. TMJ ankylosis. TMJ ankylosis is defined as a bony or a fibrous union of the condylar head, glenoid fossa, and the disc. This results in decreased joint mobility and function. It's also called as fused joint or stiff joint. So etiology, what is happening in there at the joint? There's inflammation. Why this inflammation happens? Trauma to the joint in childhood. For children, trauma causing inflammation in that area because it's highly vascular for children than an adult. The chances of TMJ ankylosis is high. And then infection. Infection in the case like if the patient has TB or staph aureus infection, Neisseria, gonorrhea, hemophilus, all these kind of infections deposit. Other than this, systemic etiology. Again, these three conditions cause autoimmune inflammation in the body. So when it happens at the joint, then they can end up having a TMJ ankylosis. So pathophysiology, you need to know interfragmentary strain theory or parent strain theory and hemarthrosis. This is what's given in your textbook. You're not going to understand that. This is a simplified way. Sorry. There's a link between the TMJ ankylosis and how much bone is there. Please take a screenshot and go through because I won't have time. I have one more topic to cover. Yeah. So if you go through this flow chart and whatever I've written, it'll be very easy for you to understand at this exam time. Classification, there are 14 classifications in so many journals and articles and textbooks of oral surgery. Please go through these two classifications. They are easy to understand, and if you know this classification, it's going to be very helpful for clinics. So Shawnee's classification is a radiographic classification. Casagian is either false alkalosis or true alkalosis. False alkalosis is when the alkalosis is extra articular, and true is when it is inside the joint, so the joint space itself is affected. Now, Shawnee's classification, there's type 1, 2, 3, 4, and 5. You can see the various types. Please take a screenshot, read through the legends of the caption of the diagrams to understand it better. Now, clinical features. This is a general clinical presentation. I am skipping that. So, unilateral TMJ ankylosis. This patient, so patient with a unilateral TMJ ankylosis, you will feel like the affected side is longer. It's because there's a loss of the mental area. So in these patients, they will have a convex profile. They'll have a gross facial asymmetry, restricted mandibular growth on the affected side. The ramus is shorter. The facial height is shorter. The affected side will show roundness and fullness kind of look. And then there's an ill-defined gonium and there's a notch. Antigonal notch is very prominent. Like you can see in that image D or image C where the antigonal notch is prominent. On palpating the preauricular area, you will know that there's no movement at all of the joint. So elongated coronoid can be seen in the affected side. Like image D, can you see that? The coronoid is elongated. Now, intraorally, you will see that the patient has reduced mouth opening. There's an occlusal cant. Occlusal cant is when you place a scale in between the teeth and make them bite. And you see that there's a cant. On the affected side will be higher and the unaffected side will be lower. And then class 2 malocclusion, they'll have a lot of dental caries, poor oral hygiene, and there'll be multiple impacted teeth. Now, bilateral, same thing on both sides. So they'll have a full round kind of face, they'll have a highly convex profile, and they'll have double chin, they'll have a reduced facial angle, they'll have elongated coronoids on both sides. Again, very poor oral hygiene, they'll be very thin, they'll have a very bad nutritional so yeah, again, the patient will have prominent antigonial notch on both sides. So radiological assessment, we take CT scan, OPG. CT scan is more easier to see how much of the joint is affected, and the ankylosis type can also be seen better in that. Management, first, the most important point is airway, because more than doing the surgery for the patient, what is important is the airway, because the anesthetist is not going to be able to intubate. The patient is not going to be able to open their mouth. In case of an emergency during anesthesia, the patient can even die. So in that case, what we used to do as an anesthetist was then blind nasal intubation, because you can't open the mouth. So blindly they put the tube in and then only anesthetize the patient, give GA. So nowadays we have endoscopes. So do an endoscopic intubation. They do not induce the patient until the airway is intact. So then we have the surgery. Surgery is, there's a lot of techniques. I'll discuss all of that to you now. So surgical approach is the gold standard, and most commonly used is preauricular approach. The Dingman's preauricular approach have shown that A is the gold standard here. These are the other modifications. So make sure you just know the names. Blaiotoma, Alcad-Bramley is a very common name that you should know. Popovich, coronal extension of the bicoronal approach. So in this, the most aesthetic is going to be the post-preauricular approach. Retromandibular or Heinz approach is also important. Submandibular is also there, but it is very difficult to access the TMJ. The most commonly used one is the preauricular or the bicoronal with an extension. So treatment protocol, this is very important. Caban's protocol is a 5-mark. So what do we do? First, what we do is an aggressive resection, that is gap arthroplasty. Aggressively, you remove the joint area, the ankylosed part. As shown in the image ABC, you can remove. After removing it, you try and, during surgery, you try and open the mouth. If it's not going to open, you will have to do an ipsilateral coronoidectomy. I already told you the coronoid will be long for these patients. So first you do an aggressive resection, then you do a coronoidectomy, and then you check if it's opening. If it's not opening, you do a counter coronoidectomy. The other side also you have to do a coronoidectomy, and then you can use you have to put something in between the glenoid fossa and the remaining bone, because if you leave it like that, the bone can get re-ankylosed. So you have to keep a temporalis fascia, or you have to keep a lining or a cartilage or something in between, and then you can close up. So for like for pediatric patients, what we do is we keep a costochondral graft. Costochondral graft is nothing but a rib graft. But the rib graft is not just going to be bone, it's also going to have a little bit of cartilage. And we place it, I can show you pictures. This is a protocol that you need to know. First is aggressive resection, then ipsilateral coronoidectomy, contralateral coronoidectomy, lining of the TM joint, reconstruction, and then early mobilization. The patient has to go for vigorous physiotherapy for 6 months. Otherwise, they're not going to be able to open their mouth. So this is Kabban modified his, the protocol was modified in 2009. So you can go through, please screenshot, memorize it. Surgical techniques. Yeah. So condylectomy is the first indication where you remove the joint, the ankylosing joint. So gap arthroplasty. So in this case, you can see we have removed the ankylosing area, and then we've received this much of mouth opening. B and H, you can see the mouth opening. Now, interpositional arthroplasty is where you keep something in between, like I told you. The most commonly done one is the temporalis muscle flap. So we raise a pedicle flap of the temporalis muscle and the fascia, and then we tunnel it down inside, put it to the medial side. Like from this side, it comes in, goes off to the medial side of the mandible, and it is sutured off under the mandible. So there is something in between the bones so that it will not re-ankylose. So we can keep so many other things also. We can keep an auricular cartilage, autogenous fat graft, dermal fat graft, buccal pad fat graft. But the best is temporalis muscle flap. Apart from that, for like I told you, for pediatric patients, can you see the graft image I? So we place that with the screws in L. You can see image L. You can see the screws. It's been placed, and then the patient is able to open the mouth. So post-operative physiotherapy. This is the physiotherapy. It is very important for these patients. After all of this, if the patient has a good mouth opening and the patient is able to have a usual normal life, then you can go for the correction of the defect itself. So in this patient, we have done distraction osteogenesis, and now the patient is able to have a normal skeletal profile. See the profile in B and M. You can compare both. These are the materials that can be used in as an interpositional graft. So this is TMJ ankylosis. The goal is to achieve function and then the aesthetics. So this is how we achieve all that. These are the complications of TMJ ankylosis. This is false ankylosis. All this is not important for you. Okay, so maxillofacial trauma. So I have discussed this. I will be discussing basic principles for the management of maxillofacial trauma and mandibular fracture and leaford fracture. So basic principles. So you know what a fracture is. There's a disruption in the continuity of the bone cortex. Primary healing is primary healing or secondary healing is what we need at the fractured site. So for that, you need an area that is not mobile, right? So once the bone is fractured, both the fragments should be kept together, and it should be immobile for 3 months so that the bone is going to form lamellar bone. Lamellar bone is what we need from primary or secondary bone healing. Primary healing is what we all want, but sometimes it can be secondary healing also. So what all affects fracture healing? Local and systemic fractures. Please go through later. If it does not heal, then there's going to be non-union, there's going to be delayed union, there's going to be malunion, there's going to be osteomyelitis, all of these. Then so how do we treat it? We either open up, do a surgery, open up, and treat it directly. You visualize the area of reduction and fixation and fix the fracture and fix it. Or you can do a closed treatment where you don't look at the fracture. This closed reduction is done only when the fracture, when you're able, like if it's a mandible fracture and the occlusion is involved, when you're able to get a good occlusion and a complete fixation, then you do an IMF, intermaxillary fixation, and leave the patient for 1 month. And then, and if the fracture is also not bicortical, like if it's only one cortex is affected, it's a hairline fracture, there's not much of an occlusal issue, then you do an IMF and correct it. Otherwise, we do an open treatment only. For conservative treatment, when we do is when there's a hairline fracture, there's no movement at all, there's no issue with the function for the patient, then we do a conservative treatment. Now, closed reduction for maxilla. What are the closed reduction techniques? We use the Rose disampaction forceps, Hayton Williams disampaction forceps, Walsham's forceps, and Ash forceps for nasal bone fractures. Mandible, only IMS is possible. For the zygomatic complex, we can use a Bristow's elevator, Rose elevator. See, all of these are used inside the surgery. It can be done only under GA, but we are not accessing the site directly. So Bristow's elevator, row elevator, all these things will help to move the fractured zygoma to a better place at the right position. So that's why all these are coming under closed reduction, because we don't go to the site immediately. Now, see, in this patient actually has a Leafoot fracture. We are using the Rose disampaction forceps, and we're pulling the fractured maxilla above, and then we do a IMF, and the patient is fine. So this is done as a pre-surgical technique right now, but yeah, you have to understand the concept. So nasal reduction using Walsham's forceps is shown in image B. Open reduction is the gold standard. This is what we do for all cases. So these are the types of IMF. So in image A, this is direct wiring where you use one wire per tooth. And image B, C, D, E is eyelet wiring where we create an eyelet. B is an eyelet, and we put that for 2 teeth. So then in image J, again another kind of eyelet wiring. So arch bar is a 5 mark for you. Arch bar is a preformed, we have a stainless steel bar which we apply over the teeth. So arch bar, it's important to know that the hook, there's a hook on the arch bar, right? So it has to, for upper teeth, it has to face downward, and for lower teeth, it has to face, for lower teeth, it has to face downward, and upper teeth, it has to face upward. So only when the hook is going to face upward and the hook is going to face downward in the lower tooth, you can actually tie it together. So make sure you mention all of that in your viva. So another use for arch bar is it is a tension band. It works like a tension band. I'll discuss that with in mandibular fracture. Now, intermaxillary fixation screws. We fix these screws onto the bone when the patient is edentulous for IMS. Splints can also be used when the patient is edentulous. You can use your denture and then create these kind of splints. Now, skeletal wiring. So these are the wiring techniques that were used before the use of plates. Nowadays we use plates, but these are suspension wires. Basically, we're suspending the fracture to a stable point on the skull. So a globular suspension can be seen in A, and a zygomatic or frontal suspension in B, a zygomatic arch suspension, C, infraorbital suspension, and then a pyriform suspension. Before open reduction was done, all of these techniques were only used. So this is external fixation using craniomaxillary fixation devices, external pin fixation devices. So when it comes to rigid fixation, see, the fracture can be fixed rigidly, that is perfect rigid fixation. So there's absolutely no movement between the fracture. So this is what we need most of the time. Rigid or semi-rigid is good enough for a fracture to heal well. So nowadays we use all mini plates, that is semi-rigid fixation. Rigid fixation is used for when you use things like DCP, compression in osteosynthesis, DCP plates or lag screws or EDCP plates or TORP or locking plates or the reconstruction plate that we use for cancer defect and all that. So non-rigid fixation is transosseous wiring. We don't use transosseous wiring unless for nasal fractures as much, but it's important to know the history of this. So semi-rigid fixation for mandible, you need to follow the Champy's line of osteosynthesis. The orange line is Champy's line of osteosynthesis. Basically, for a proper semi-rigid fixation, especially in the area of the external oblique ridge and the anterior, you need two plates in these two areas, because otherwise there's going to be you are not going to get a semi-rigid fixation. So that is what Champy's line is. So non-compression mini plates, they are available in 2 to 2.5 thickness, ranging from 4, 6, 8, and 10. 3D mini plates are also there, where you have these box kind of plates in image A. Image B is resolvable plates. We do use it for pediatric patients. So I'm just going to skip through all of this. It's not very important for you. Just make sure you know what DCP is and EDCP is and lag screw is. Because see, when it comes to DCP, dynamic compression plate, basically what happens is you place the plate and then you put the drill, you fix the screw as in image 2, and then when you twist the screw some more, it will move into the socket that's going to bring the bone together. So that's what you see in image C. And then there's two more holes where you put just normal screws for the bone to be in a stable position. Now, additional tension bands, see, like I told you, Champy's line, you need additional bands, because when you fix one screw at the bottom part, the fracture can actually open up in the top. That is why we do an arch bar wiring. So if the tooth is already fixed, there's a tension band between the teeth, and then you place the mini plate at the fracture. Then there's gonna be a better occlusion of the fracture sites. Now EDCP is another type. It's exactly same as dynamic compression plate, but the pattern of the plate is a bit more better than DCP. You can take a screenshot and go through it later. Now, lag screws used only for oblique mandibular fractures. Okay, so again, it can't be used in the condyle, but other oblique fractures, they use this lag screw. It's when you put the screw, and as you start tightening, the screw will actually pull the fractured segment towards it. So bringing both the bone together. So that's what lag screw is. Again, we can use mandibular reconstruction plate for rigid fixation. Locking plate, again, rigid fixation. Mandibular fracture. This is a very common fracture for the face. I think it's the second common fracture, because the first one will be nose fracture. So the fracture pattern is important. You should understand the fracture. Is it a direct fracture or an indirect fracture? When you understand the trauma, is it a direct trauma or indirect trauma, you can actually predict the fracture itself. You have to be important. I mean, if there is a direct trauma, the chances of two or more places fracturing is high. Now, buttress of the mandible, there's a vertical and horizontal buttress, as you can see in this image, and the muscles are also involved. So, for a fracture, like the favorable and non-favorable types of fracture, all that are caused because of the movement of these muscles. Like in a simple parasymphysis fracture can actually become more difficult because of the muscles pulling it. So favorable and unfavorable fracture can be different just because of the type of fracture. So in this image, you can see just because of the oblique fracture, direction of the fracture, more extensive fractures become a favorable fracture in A, but an unfavorable fracture in B. This is because of the muscle pull. So, classification of mandibular fracture. This is Dorland's fracture classification. Simple or closed, compound or open, commuted, green stick, pathological, multiple, impacted, atrophic, indirect, and complicated or complex. Dingman and Natwix is a more common classification. In this, we have midline fracture or symphysis fracture, parasymphysis fracture, body fracture, angle fracture, ramus, condyloprosis, coronoid, and alveoloprosis. This is another classification. You don't need to put in all of this. Clinical features very important. Patient is going to have a Coleman sign in mandibular fracture. Coleman sign is image D. There's a sublingual ecchymosis. So please take a screenshot or go through this. You will have to write down all of these clinical features for your 5 marks. So radiological examination, we need OPG or lateral oblique or posterior anterior view, occlusal view, reverse down view, TMJ view, and CT scan or CT scan. So treatment, what we do is first we do a tension band wiring as in B, and then we can do a closed treatment if it's a favorable fracture, and if it's a simple fracture, then you can do a closed nose where you do an IMF. A period of IMF is up to 3 to 6 weeks. Now, when we do an open reduction, that's better. And always, see, IMF is done, closed reduction is done when the patient has some kind of a systemic issue or he's not stable because of the trauma. They might have any neurological issues. So, in that case, a no closed reduction is done. For open reduction, any normal healthy patient with just a fracture, you have to go for an surgical approach. The approach is mostly intraoral, should be possible. Or else you can do a submental or submandibular, retromandibular, and preauricular is done for condylar fractures. So if the fracture is at the symphysis or parasymphysis, first we do an MMF, then we do an ORIF with mini plates. Body fracture, single 4, again, symphysis parasymphysis fracture, you have to use 2 mini plates based on the Champy's line. Now, body fracture, 2 mini plates can be used if the tension band is not applied. Mostly, 1 single 4-hole plate is enough. Angle fracture, we need 2 mini plates, and IMF up to 8 weeks. Ramus fracture, we will have to do a preauricular or a submandibular approach, because we are not going to be able to access the coronoid ramus or the condyle through an intraoral approach. So for these fractures, you have to do an extraoral approach. This is a case showing a fracture and how it was treated. Tooth in line of fracture, if the tooth is affected, best to remove the tooth. But if the fracture is not going to completely come in proper fixation, like complete reduction is not possible, in that case also we remove the tooth. So teeth that has to be retained is when the second molar is not present. We'll have to take some effort in retaining the tooth. If otherwise, if the tooth is a third molar and it's not in use, then we can remove it. Edentulous fracture. This is a very common edentulous fracture, and it's called as buccal handle fracture. It's a VIVA question, so please go through this. For edentulous patients, we can do a close reduction using gunning splint. We can modify the denture or take an impression and create a gunning splint like this and do an IMF. Pediatric mandibular fracture. Again, IMF cannot be done for more than 2 weeks for these patients, and ORIF can hurt the tooth buds. So we use biodegradable plates, and it has to be fixed at the places where the tooth is not there, the permanent tooth. Leaf fracture. So we need to understand that the face has some buttresses, the frontal bar, the orbital bar, and the maxillary alveolus. These are the buttresses, the horizontal buttresses. The vertical buttresses are going to be the orbital buttress, the nasomaxillary buttress, zygomaticomaxillary buttress, and the pterygoid buttress. So in case of a fracture, these buttresses help to protect the face by breaking and protecting the more serious structures inside. So Rene Lefort classified Lefort fractures as 1, 2, and 3. Lefort 1 is called as Gurian fracture or a floating maxilla fracture. The fracture line extends from the lateral margin of the anterior nasal aperture below the zygomatic buttress, crosses to the lower one-third to the pterygoid laminae. Posteriorly, it runs across the lateral wall of the nose, a part of the septum, and then the tuberosity. So now Lefort 2 is called a pyramidal fracture because maxilla, the line of fracture starts from the middle area of the nasal bone, frontonasal junction, and then to the medial wall of the orbit, the lacrimal bone, and then goes to the infraorbital margin, and then it goes to the back of the maxillary antrum, and then to the pterygoid laminae. So it separates the maxilla completely from the skull, so it's called as a pyramidal fracture. Lefort fracture 3 is when it goes inside the orbit. So you can read through the fracture line. So within the orbit itself, it has a separate course. It runs backward to the pterygomaxillary fissure later on, and then the pterygoid laminae. The Lefort 1, 2, and 3, it breaks at 3 different levels at the pterygoid laminae. Yeah. You can see image C. There's image E again. See the pterygoid area, the middle part of the pterygoid area is affected. In image G, the entire pterygoid is removed. So these are classifications. That one classification is enough. Rowe and Williams classification can also be followed. You can take a screenshot. So clinical examination is important. How we examine the patient. So first we keep a left hand over the face, and then we hold the patient's head, move the maxilla up and down to see which part is affected. These are the clinical features. The most important feature for Lefort 1 is the crackpot sound on palatal fracture and the Gurian sign. Lefort 2, Gurian sign is ecchymosis of the palate. So Lefort 2, the patient will have a moon face appearance, he'll have raccoon eyes, both eyes will have edema, infraorbital step deformity will be there, CSF rhinorrhea may be there, mobility of the face can be seen at the nasal bridge itself, you can see the movement. Again, crackpot sound will be there. For Lefort 3, patient will have panda face, dish face deformity, and then telecanthus, hooding of the eyes, anti-mongoloid slant, and all that. You can see all of those in this. You can take a screenshot if you want. Now, radiograph. See, this McGregor and Campbell line is important for Lefort fracture because these lines, there are these 5 lines that's mentioned. You see this on an occipitomental view or a Waters view. In this view, when you see these lines, you can see how the fracture is also differentiating. But nowadays, we do a CT scan and it's much more easier to see all that. You can take a screenshot. This can be a Viva question. Management, so reconstruction and achieving reduction and fixation is most important. Immediate repair is recommended only for stable patients. Delayed repair for patients who are neurologically affected. So these are the approaches for Lefort 1. See, transoral or intraoral approach can be done for Lefort 1, 2. See, mid-face degloving is another procedure that we do for 2 and 3, Lefort 2 and 3. So transcutaneously, we do an infraorbital, subciliary, all these things for these fractures around the orbital floor, medial, lateral wall fracture, and all this. Lateral eyebrow incision and all is done for Lefort 3 because these areas also need to be fixed. Coronal incision is done when there's when we need to access all these 3 places. We can do a coronal incision. Most commonly used is an intraoral with a transconjunctival to fix the orbital floor. So this is a maxillovestibular approach. See this, we just open up the vestibules and we can fix the fracture. This is midfacial decurving, where we remove the entire the midface to access the fracture. In this itself, we can fix up LeFo3 also in most cases. Reduction of the fracture is using these disimpaction forces. So how do we fix the fracture? We can either do an internal fixation that I've already discussed, the transosseous wiring or suspension wiring. See, all of this you can do for medically compromised patients. But now what we do is completely manipulate osteosynthesis. So these are the different internal fixation techniques. We can do wiring, we can do many plates, or we can do a Fisher's wiring, or we can do suspension wiring. This is an external fixation technique. So this is management of LeFo1. These are notes, my notes. Please take a screenshot so you can write this, go through it easily, learn it, and write it for your exam. This is a case showing LeFo1. You can see where the mini plates have been used to fix the fracture. This is LeFo2 and 3. Please take a screenshot. Again, this will be very easy for you to read for your exam. This is LeFo3 and a case. You can see the occlusion is changed. The patient has enophthalmos, and you can see how we fix the orbital rim in image F. And image D, we fixed the maxilla to the both the segments. We fixed it, and we've also got a good occlusion in image G. This patient has a medical complication. He's an aged patient. So for this patient, we've done a suspension wiring for LeFo. These are the complications. Thank you.
Thank you, everyone. Thank you for joining the session. And we appreciate your engagement, and we look forward to connect with you again. Thank you for being a part of our learning community. Thank you so much, ma'am. Thank you for taking. Yeah.
I think there are some questions here. Oh, BSSO in a detailed way.
So these are yes. So these were all requests, ma'am. These are not questions exactly.
Oh, okay.
Yeah. So, I just want to tell everybody, if you still have questions, you can send it to us, or you can, you can get in touch with me if you have any further questions. So we'll make sure that those questions are answered. We'll share those questions with Dr. Preetha, and we'll make sure that those questions are answered. Thank you so much for joining.
Thank you.